topic. I do appreciate it's a very heartbreaking news now coming from Gaza, and it's a very difficult time. Adhu Allah subhanahu wa ta'ala, I hope inshallah Allah subhanahu wa ta'ala will ease it down for them, protect them, and inshallah they will be inshallah the situation will be much better very, very soon. Dr. Hossam, تفضل.
السلام عليكم ورحمة الله وبركاته. بسم الله الرحمن الرحيم والصلاة والسلام على محمد وآله وصحبه أجمعين. والسلام عليكم ورحمة الله وبركاته. I am honored to be the guest speaker at today's program. I thank Professor Sharif Kaf Al-Ghazal and the team of the History of Islamic Medicine at the Federation of Islamic Medical Association for the invitation. I have to say, or start by saying that it is sad that while we are discussing the glories of the past, we stand witness to massacre of thousands of our brethren in Gaza. Hospitals are destroyed and patients are dying because of lack of medical care. This is happening while the whole world is watching. Most are not willing or able to stop these atrocities, while others are actually cheering them. We pray to Allah to protect and have His mercy on the Gazan people and all oppressed people all over the world. Wallahu musta'an. I'll start my program today, and as you have, the program is the contribution of scholars in the Islamic golden age of obstetrics and gynecology. The first revealed Quranic verses point to the importance of learning. Read is the first word, and taught by the pen is towards the end. There are multitudes of verses throughout the Quran that describe Allah's miracles and ask the reader to think, ponder, and contemplate. There are several prophetic ahadith that urge Muslims to seek knowledge. When the earlier Muslims took heed of these instructions, they excelled in science and other aspects of civilization. Hence, we refer to this era as the Golden Age. So there were numerous significant contributions to medicine by the physician-scientists belonging to this era. Many of these contributions have been largely ignored by Western historians. It is our responsibility to correct this deficiency. In today's presentation, I will highlight some of these as related to obstetrics and gynecology. I will be enumerating some of these scholars' observations, clinical findings, diagnostic procedures, and treatments. I will add I will add how these relate to our current understanding. It will be clear that these scholars had a good and occasionally impressive understanding of some physiologic facts and pathologic conditions. Al-Zahrawi was the first to indicate that the pregnant uterus relaxes and contracts. It relaxes to allow the pregnancy to grow. That's the effect of progesterone. And to contract during labor to push the baby out. That's the effect of oxytocin and prostaglandin. Al-Majusi was the first to state that delivery results from uterine contractions pushing the fetus out. Before that, it was thought that labor pains, that's the contractions, only indicate the onset of labor, and subsequently the fetus pushes itself out. Hippocrates, for example, likened the process to the chicken hatching of the egg. This is an example of how the Muslim scholars studied previous writings, but corrected many of the wrong information. Al-Zahrawi correctly noted that twins can be present in one sac, we call it now monoamniotic, or in two separate sacs, diamniotic. This is an illustration of these types of twinning. On the left, we have the two fetuses without any separating membrane, but on the right, they are separated by a membrane, and this is what we call dichorionic, two placentas and two amniotic sacs. Both Ibn Sina and Arib al-Qurtubi described malnutrition-related amenorrhea, obviously amenorrhea for meaning the lack of menstruation or absence of menstrual cycles. They did say that very thin women do not menstruate, which is equivalent to what we recognize now in anorexia nervosa and related eating disorders, or what's occasionally seen in athletes. Musa ibn Maymun described a type of amenorrhea, special type of amenorrhea that is associated with swelling of the breasts and appearance of milk secretion, which we call galactorrhea. This is probably the first description of what we now know as hyperprolactinemia-associated amenorrhea, commonly caused by pituitary macroadenomas. Al-Zahrawi did state that obesity can be associated with amenorrhea. Ibn Sina further described that women that are obese and look and behave like men, and they are obese and muscular as being associated with amenorrhea. But Musa ibn Maymun really went even further. He said that these are women whose skin is hard and whose features resemble the nature of a man. Their voices is loud and they are generally big. They can become bearded and may not menstruate at all. These are probably the first references to what we call now polycystic ovary syndrome. This is a picture of a patient with this syndrome. As you can see, she looks like heavy built, probably like a man if you're not very careful. You see her mustache and beard, and on this but the left side of that is a diagram showing what polycystic ovary is. Normally, the Griffin follicles will mature and rupture, that's ovulation, every cycle. But in these cases, they fail to rupture and they turn into a cyst. So that's why we call polycystic, a lot of cysts in the ovary. Ibn Sina was described what we call imperfect hymen. He called it rithqa. And he stated something on the mouth of the genitalia, whether it be a muscle or a strong membrane that prevents the flow of menses, intercourse, and pregnancy. He continues, it is usually there, this imperfect hymen, or rithqa rather, from the beginning, from the time of birth really, but becomes visible when the woman starts her menarche. Menstrual blood cannot exit. The woman suffocates and perishes. We understand this because when the blood is retained in the vagina, it's called hematocolpus, and then further becomes in the uterus, hematometra, gets secondary infection, becomes pyometra, leading to septic shock and eventually death. Ibn Sina continued to describe his treatment. He said it should be cut in the middle of the genitalia until the two sides, that's the labia majora, are separate. If there's an extra tissue, this should be removed, but not taken from the original genitals. Then one should leave a piece of wool soaked with oil and alcohol for 3 days, and ointment should be added gradually or regularly to avoid refusion or narrowing, which is a very insightful recommendation. It's applicable to all situations where a new opening is furnished. Early Muslim scholars paid a lot of attention to conception and pregnancy, basically. They did realize that the female ovaries are equivalent to the male testes. And they did describe that ovaries produce fluid. They did not recognize that the ovary actually releases the eggs or the ova, obviously because this is microscopic structure. But they knew that this is coming out of the ovary and they have to call it a name, give it a name, fluid, to correspond to the male semen. they realized that the best chance of pregnancy is when male and female orgasms occur simultaneously. They explained that by the fact that the female orgasm will cause movement of the uterine mouth or the cervix that normally function to attract and suck the man's semen or sperm inside the uterus. At the same time, the orgasm will push, the contractions of the uterus will push the ovarian fluid into the uterus where it meets the semen, As we know, Islam did not prohibit contraception, but left it to the couples to decide whether they want to use it or not. However, Ibn Sina did recommend contraception in special situations, specifically for young women. He thought this is dangerous for them to get pregnant, and for those who are, or rather encountered, urinary bladder damage in a previous pregnancy. Their methods of contraception were relatively simple. Number one, to avoid simultaneous male and female emissions or orgasms. They did have, and he and others had, several prescriptions for herbs to be inserted in the vagina. Ibn Sina recognized that taking certain drinks, such as basil, can prevent pregnancy, the first indication of an oral contraceptive or possibility of an oral contraceptive. Abu Bakr al-Akhawani described placing a barrier made of mazu, which is really oak tree sap, at far end of the vagina, in front of the cervix, to prevent the semen from entering the uterine cavity. He recommended that this barrier should be connected to a thread for easy removal after intercourse. Likely, it is the first prototype of a removable contraceptive device. That's what we use now, the vaginal diaphragm. He also advocated penile sheath made of animal gallbladder, and this represents probably the first prototype of the modern condom. Infertility was a significant problem that they addressed. So they did realize it can be caused by either female factors or male factors or both. It's something that we definitely agree on at this time. Ibn Sina described that anger, fear, sadness, or poor mizaj, those who know Arabic, mizaj is the mood, are contributors to infertility. He did document that in the male, it reduces the quality of the sperm. Al-Razi added that a woman who is always sad and miserable will not get pregnant. They all observed that obesity can be associated with infertility. Al-Razi added other possibilities of infertility or causes of infertility as blockage of the mouth of the cervix by thick secretions, which we do definitely think is true. He also said that hard swellings of the uterus, which we call fibroids, can prevent the mixing of the male and female fluids. And they talk about obstruction of the female genital tract that prevents the meeting of these fluids. Al-Zahrawi actually described what he called uterine horns that connect the uterus to the ovaries. He did not call them, that we know now as the fallopian tubes. He did not specify the word tubes, but he described them as uterine horns. The scholars of that time, even though they know that there's a connection between the uterus and ovary, did not specifically tubal blockage as the cause of the genital tract obstruction, but they call generic blockage of the female genital tract. Ibn Sina observed that an infertile couple sometimes later conceived children with other mates and concluded that some kind of incompatibility caused infertility. This is now recognized as immunologically mediated infertility. Basically, the female sometimes will produce antibodies, usually in the cervical mucus, against the husband's sperm that will kill them. These anti-sperm antibodies will not destroy the sperm of a future husband. Ancient Egyptians used garlic to detect to predict normal delivery. What they did is put the garlic and inserted it in the vagina at night and have the woman body wrapped completely except her head. If she smells or tastes garlic in the morning, then her delivery will be normal. The illustration to the left of the here indicates 6 clay models of the garlic that were discovered in the Naqaba tomb, pharaonic tomb around 3500 BC, before Christ. Muslim scholars realized that garlic test had no relevance to normality of delivery. However, they utilized it to diagnose the cause of infertility. We talked about one of the causes of infertility they talked about is genital tract obstruction. So they used it to find out if the genital tract is obstructed or not. So they put the garlic in the vagina, and again, if the woman smells it or tastes it in the morning, then there's no genital tract obstruction and she is fertile. This is another evidence that the Muslim scholars knew about and studied previous medical practices, but corrected their misunderstandings. Sometimes instead of the garlic, they used herbs with strong scent, like vapors. For the treatment of infertility, they emphasized the synchronization of orgasms. Ibn Sina went further to stress the importance of foreplay to achieve that. They also talked about loss of weight as a good option for treatment of fertility, and all prescribed different herbs to be taken orally and others to be inserted vaginally. On another topic, the Al-Razi described solid uterine tumors and called them waram leafy. Again, Arab speaking will know what leafy means. Leaf is actually fibers. And this is a very apt name for these tumors because they are consist primarily of fibrous tissue. And that's why the name fibroid is still used until this moment. These uterine tumors or fibroids, or waram leafy as Al-Razi called them, can cause heavy bleeding, they can cause infertility, and they cause pressure symptoms. According to him, especially those present in the uterine neck. This is a diagram where the fibroids can be present in the fundus of the uterus, the body of the uterus, or in the cervix. And this is one illustration of the cervical fibroid in the cervix. And the cervix, compared to the uterine body, is relatively fixed and surrounded by other pelvic organs, specifically the urinary bladder and the rectum. Pressure symptoms are common with the cervical fibroid, as you can see from this, is compressing the rectum. Pressure symptoms can occur with the corporeal fibroids in the present of the body, but only if they are very big. Also, Al-Razi described what he called ulceration of the neck of the uterus secreting pus. I believe that he was referring at that time to what is known as, as we know now, as cervical cancer. He noted that these lesions can infiltrate surrounding pelvic structures, leading to hard, non-mobile uterus. That's obviously advanced cervical cancer. The vaginal speculum really was invented by and used by Al-Zahrawi. It was called Miftah al-Farj. Again, those who know Arabic means exactly what it is. It is the vulvar key or the vulvar opener. Ibn Sina added a mirror to the speculum to improve vision or improve visualization. And he used also several sizes depending on the size of the vagina. Both Ibn Sina and Al-Zahrawi described the lithotomy position for gynecologic procedures and for delivery. Later on, a Turkish physician, Sarifuddin, in the early 15th century, described and illustrated the lithotomy position and the different procedures that were done in that position. In his book, I cannot do the Turkish name exactly, but it means imperial surgery. This is a diagram showing the design by Al-Zahrawi. As you can see in the center here, he put this in the within the vulva, and using these screws from both sides to open the vulva so that you can visualize the inside of the vagina. This is a replica of this design by, of the speculum by Sahrawi. This replica is present in the Fuad Sijin Institute for the History of Science in Islam, which is available, which is present in Istanbul. This is an illustration of uterine prolapse. As you normally, the uterus will be in the pelvis higher up, but in prolapse, it will be down, basically between the rectum and the vagina, and in more severe cases, it protrudes outside the vulva. Ibn Maymun was likely the first author to write that uterine prolapse occurs in women who were pregnant many times, multiples, especially if their deliveries have been difficult. He explained that the force of expulsion weakens these pelvic muscles. We do agree, or we do, this is the effect that we agree with. Actually, uterine prolapse was also mentioned as a complication of difficult delivery by another Muslim scholar, Ibn al-Baladi. If we move on to the obstetrics, we'll talk about prenatal care. Ibn Sina stressed the importance of healthy lifestyle of both parents. He described exercise, nutrition, retention of necessary materials, that's the good nutrition basically, and excretion of body waste, and mentioned psychological balance to be an important factor. He also stressed the importance of climate and fresh air, demonstrating that Muslim scholars have a holistic approach to treatment. Al-Baladi is really should be credited for being the first one to describe prenatal care or make it as a separate entity. He had a whole book for that. It is called Tadbir al-Hawamil, Tadbir al-Hawamil, or management of women, their children, boys, and their diseases. This is currently Al-Baladi went further to describe many of the symptoms of pregnancy that are commonly known. This morning sickness, craving, or what is known as waham in Arabic, sialorrhea, that's excessive salivation. He describes swelling of the lower limbs, stria gravidarum, which are the stretch marks, and breast engorgement. He added that if the breast, after being engorged, they start to be shriveled, or he called it shriveled or retrogressed, this indicates that fetal weakness or even fetal death. The same observation by Al-Razi and Ibn Maymun. Currently, we understand this shriveling of the breast to be a result of low levels of prolactin and progesterone, secondary to severe placental insufficiency, which can be associated with fetal death. Al-Baladi went on to recommend several very nice recommendations for pregnancy. I will mention a few of them, or some of them really. He said that the pregnant woman needs more nutrition, but not too much, as this may disturb the stomach and digestion. The increase should be moderate and consist of easily digested food. The increase should be gradual and in successive stages, accompanied by an increase in exercise. He also addressed sexual activity during pregnancy. He said, it is better to avoid it in the first 2 months and after the 6th month. At that latter time, the fetus is heavy and cannot be trusted to fall during intercourse because of the excessive movement of the couple at the time, and the fetus is already ready to get out. By the way, these are the same recommendations we give to women at risk of repeated miscarriages or risk of preterm delivery. Al-Razi stated that fetuses normally present by the head. If it was presenting by the breech, it turns into head by the 8th month, as the head is the heaviest part of the fetus and will gravitate downwards. He further added that fetuses delivered before the 8th month commonly present as breech and they usually die. He explained that by they are weak and therefore could not turn in the head first position. While it is true that a higher percentage of preterm deliveries are breech, but the higher death rate is primarily because of prematurity. But it is also true that breech delivery is more stressful to the fetal head, especially to the less ossified skull of a preterm fetus. Al-Razi also described if a foot or hand presents, it can cause death of the fetus and mother. He is probably referring to breech and transverse presentation with prolapsed arm. Specifically, in the transverse presentation will result in obstructed labor, and this will result in, if unrelieved, ruptured uterus and usually maternal death. Again, for non-obstetricians, just to remind you that the kind of presentation is to have longitudinal lie with the head down, that's vertex presentation, longitudinal lie with the breech down, breech presentation, or the transverse lie where the fetus is lying across the fetal, across the maternal abdomen, or cannot be delivered that way. And again, this is what we call sometimes shoulder presentation with the prolapsed arm, or footling presentation with one of the foot prolapsing down. Also, Al-Razi described the malpresentation of the umbilical cord around the neck, and it is true that it can be a cause of difficult labor and fetal death, according to his statement. Now, we'll talk about the onset of labor. Ibn Sina stated that initiation of labor occurs when the fetus cannot get enough blood, quote unquote, nutrition from the placenta. We call this placental insufficiency at this time because as the placenta gets older and the pregnancy advances, its efficiency in transferring nutrients to the fluid, to the fetus, and the exchange of gas decreases. And it is placental insufficiency is implicated in theories of onset of labor. Now, if it goes to the extreme and pregnancy continues beyond dates, the placental insufficiency sometimes will be great enough that it will cause fetal death in post-datism. Ibn Sina continues that at that time, when there's a placental insufficiency, the fetal organs are completely developed and it starts to move downwards towards the exit, usually starting at the 7th month and it comes out on the 9th month. Delivery occurs when the membranes are torn. Al-Razi added another statement saying sexual intercourse brings in labor and facilitates delivery. This observation is now explained by the effect of oxytocin release and the position of seminal prostaglandins in the vagina. Both are oxytocic agents that initiate and potentiate uterine contractions. In his description of the management of labor, Al-Razi instructed midwives to first examine to find the degree of cervical dilatation and to ascertain the presenting part, and only to have the parturient pushed down when the cervix is sufficiently dilated. Obviously, a very accurate statement that we follow all the time, not to have the woman push until the cervix is fully dilated. Ibn Sina classified causes of difficult labor, which we call dystocia, into maternal, fetal, falls in the uterus or the placenta, timing of delivery, either preterm or postterm, or mistakes by the midwife. This is still a very valid classification that we follow. For maternal causes, he explained that the patient may be, or the parturient may be weak malnourished or diseased, either too scared, very young or old, that obese, restless, or impatient with labor pains. But he added that their causes could be tumors of the bladder, rectum, or colon. He also added urinary retention or impacted hard fecal matter, all very clear causes for difficulties. As for the fetal causes, he mentioned female gender, which we probably don't agree with now, big size, big head, or being too small, like light, such that it cannot forcibly fall down. By the way, this indicates that he has still some belief in the theory of Hippocrates that the fetus is the one who actually causes the delivery to proceed, that the fetus swims down along the birth canal like the chicken hatches out of the egg. Or if the fetus have an anomaly such as a double head or a malpresentation or more than one fetus. Also, he mentioned a dead fetus cannot help in the process. Uterine causes include small size. Probably he is referring to what we call now contracted pelvis. He also listed improperly healed cervical tears or ulcers or hemorrhoids of the uterus. He did not explain what hemorrhoids of the uterus mean, but probably, at least in my thinking, it relates to placental abruption. In the diagram here, or illustration, you can see the edge of the placenta separated from the uterine wall and the blood accumulating between the baby and the uterine wall. As placental abruption causes episodes of bleeding associated with abdominal pain, possibly similar to hemorrhoids, and that's why he called this uterine hemorrhoids. He also described a thick placenta as a cause for difficult labor. Again, he did not specify what he means by thick placenta, but to my mind is that the placenta normally is present on the top of the fundus or on top of the uterus or the fundus. But if it is present in the lower uterine segment, which we are calling placenta previa, if one examines, then he will find that there is thick placenta in front of his finger. So that's why he discovered, he supposed that he called it thick placenta. He also ascribed the difficult labor to premature rupture of membranes and quote unquote dry uterus, which we call now oligohydramnios. He explained that by that the fact that the uterus is dry, that the birth canal is not slippery to allow the fetus to go out. Ibn Sina did describe the management of difficult labor in vertex presentation, and this is very interesting. He wrote in the canon, apply a sling or a fillet around the child's head and endeavor to extract it. If this fails, quote unquote, the forceps are to be applied and the child extracted by them. If this cannot be accomplished, the child is to be extracted by the incision of the head, as in the case of dead fetus. So probably he was the first to use an instrument to be applied to the head of the live fetus and to pull it out, hopefully alive. That's a precursor of the obstetric forceps. As we know, the invention of the forceps is usually ascribed to Chamberlain in England in the 16th century. So who knows if he took some indication from Ibn Sina. Ibn Sina continues, say, if the head bone is big, open it up so the inside fluid or inside liquid flows out, probably describing hydrocephaly and craniotomy. He also described how to deliver a fetus that is coming by the jamb. Again, in Arabic, jamb is the side or transverse presentation. First by manipulation, which is internal podalic version, if unsuccessful by use of kalalib or hooks, and if unsuccessful by dividing it into pieces or evisceration. This is what internal podalic version is. It was really described in more detail by Al-Razi, and the way it is done is the operator puts his hand on the fetal head, try to push it upwards, while his other hand is in the vagina, finding the feet or 1 foot or at least 1 foot or both feet and pulling them down and delivering the baby as a breech. This is called internal podalic version. Although all scholars discuss the management of some of the fetal malpresentations, but it is Al-Zahrawi who really should be credited with a detailed account of all types of presentations. And he described maneuvers to effect delivery under each of these circumstances. If he is unsuccessful, or he would resort to changing the position of the parturient, shaking her, placing her in a special seat, Valsalva maneuver. But if in all these unsuccessful, use of whole host of herbs, but if all fails, he will resort to the use of surgical instruments. And we'll mention this in more detail later on. So Al-Zahrawi described more than 200 surgical instruments, almost all of which were illustrated in his famous book, Al-Tasrif, لمن عجز عن التأليف. Many of these instruments were of his own design. They were to be used in all surgical specialties, urology, orthopedics, etc. But many are used in gynecological examination and treatment, and others were used to manage malpresentations, and others were used to deliver and extract dead fetuses. These illustrations probably form the basis of the design for several of the modern obstetric instruments. Here is an example of scissors or maqas that he can use or can be used in clidotomy, which is cutting of the clavicle in shoulder dystocia when the shoulders shoulder girder is too broad that cannot be delivered. We cut one clavicle or both clavicles to enable the fetus to be delivered. Also, these scissors are going to be used in evisceration, thus cutting the fetal organ in pieces. Another instrument was called the al-madfa, or the thruster. And this is also, you can see the handle here, and on the other end, this pointed edge, end. It is used to perforate the fetal head in obstructed vertex delivery or specifically in hydrocephaly. These are different examples or other models of perforators that are illustrated in Al-Tasrif book. Another instrument that he described is called al-mishdakh or cephalotripe, and these are used to crush the fetal head in obstructed vertex delivery or extraction of dead fetus. You can see the handles on this side, and the other side you can apply to the head or to the different fetal parts, either rounded or straight-ended. And as you can see, there are also teeth, like you saw in these instruments. These are other models that have been illustrated in his book. And this is more fanciful picture in color. It's interesting to read some of his notes here with his handwriting here. No, okay, I cannot read it now. There's some covering it. But anyway, he does illustrate, and he says that أعلم أن هذه الأشكال الآلات كلما كثرت أنواعها وكانت معدة عند الصانع كانت أسرع لعمله. Like he recommended that the operator have these different kind of instrument all together, and the more that he has is better for him to be able to work more rapidly, and also it will increase her status in front of his contemporary people at that time. Or his peers. This is actually an image of replicas of the mishdakh that are present in Professor Dr. Fuad's Surgeon Institute of History of Science in Istanbul. Ibn Sina discussed the management of the fetus that there is no hope of being born alive. He considered that labor lasting for more than 4 days, the fetus must be dead. He advised quick delivery, otherwise the dead fetus will rot or swell and its extraction will become more difficult. He would use ointments and grab the fetus, manipulating with hooks and then, or manipulating to be extracted. If unsuccessful, he advised attaching hooks and cutting the fetus in pieces or evisceration. Al-Zahrawi described in detail the extraction of a fetus after failed attempts at delivery by the previous techniques that he uses, and he believes that the fetus will be dead by that time using scissors, hooks, or sonara, and a crusher. His description demonstrates his great experience and skill. This is examples of so many different sonaras. By the way, sonara is used like fishing rod, actually, with either single hooks or single branch and multiple hooks or multiple branches. All scholars noted the need to completely for delivery or complete expulsion of the placenta after delivery and discussed how to effect its removal. Al-Zahrawi stated clearly, it is necessary that not a scrap of the afterbirth be left behind in the womb. The same statement that we teach our residents to be sure to do. He recommends first let the woman sneeze while closing her mouth and nose, then use vapors or certain herbs introduced in the uterus while the woman is sitting. If this fails, he described that it has to be manually removed, and he described that technique. His description is very thoughtful, methodical, and detailed. It is not different from what we now do. As you can see from the diagram here, the operator puts a hand on the top of the uterus and another hand vaginally and trying to separate the edge of the placenta from the uterine wall. The Al-Zahrawi stressed the importance of separating the placenta from the uterine wall gently and then pulling from side to side, avoiding violent pulling that can result in rupture of the uterus or inqilab of the rahim or uterine inversion. If we pull the placenta while it is still attached to the uterine fundus, inversion will happen. Inversion here showing that the diagram here, this is like the first degree cupping, gets worse, becomes into the lower uterine segment, and then in the vagina, and complete inversion, the uterus will be completely outside the vulva, and this is very dangerous and usually ends in maternal death. Al-Zahrawi realized that sometimes removal of the placenta is impossible, and he called that adherent placenta. We now call it placenta accreta. He was probably the first to describe this condition. In this circumstance, he injects tetrapharmacone ointment in the uterus that will soften and dissolve it or cause its putrefaction. That's the word he used, putrefaction in a few days. That will loosen it and then it will come out. This is a very interesting thing that in obstructed labor, if the head is being obstructed in the pelvis, it is the vaginal wall and the bladder base are crushed between the fetal head and the pubic bone and becomes necrotic and ends up in making a hole or a fistula between the urinary bladder and the vagina as shown in the diagram. Ibn Sina was the first to associate prolonged and difficult labor with intractable persistent urinary incontinence, which we now call vesico-vaginal fistula. Al-Zahrawi was the first to describe a case of abdominal or extrauterine pregnancy. In here, in the diagram, you can see the uterus, which is empty, obviously, and that the fetus is growing outside the uterus in the abdominal cavity. Normally, the placenta is attached to bowel or other organs, and that's why it is usually very dangerous, because after a while it separates and internal bleeding happens, and if not corrected, there's obviously abdominal, emergency, and the mother can die. In the case of Zahrawi, for some reason, this process does not happen and the fetus did not grow for so many weeks probably. Anyway, the fetus died and the placenta remained in situ. When he started seeing her, there was abdominal swelling, and after a while, this extrauterine sac turned into an abscess, which started drainage with extrusion of the bones of the dead fetus. He obviously, once this happened, he realized that this must be a fetus present in the abdominal cavity, because he knew there's no bones in the abdominal cavity normally. With proper treatment, evacuation, and dressing, the woman survived in good health for a long time. His description of the case and its successful management demonstrated his great clinical acumen. In summary, the scholars of the Golden Age had demonstrated better understanding of reproductive physiology than their predecessors, accurately described and documented many new and valid clinical observations. They showed great respect for women's health, including psychological well-being, and cared for their ailments. They did not shy away from discussing sexual health. They paid great importance to contraception and infertility. They invented prototypes of the condom and vaginal diaphragm, and at least had the concept that some herbs or medication taken orally can facilitate conception, and others that may be useful as contraceptives. They invented instruments, the vaginal speculum by Al-Zahrawi, obstetric forceps by Ibn Sina, obstetric instruments to effect delivery in fetal malpresentation and extraction of dead fetuses, like the mishdakh or crusher, perforator, the midfa or the thruster, sinara or hook, etc., all by Al-Zahrawi. Muslim scholars were the first to recognize immunologically mediated infertility. That's Ibn Sina, the polycystic ovary syndrome, Ibn Maymun, galactorrhea associated with amenorrhea, Ibn Maymun, vesico-vaginal fistula, Ibn Sina, extrauterine or abdominal pregnancy, Al-Zahrawi, placenta accreta, Al-Zahrawi, use of animal gut in suturing, Al-Zahrawi, the antiseptic properties of alcohol and the cotton to stop bleeding, and linen for wound dressing, both Al-Zahrawi and Ibn Sina. I'll stop here, and I'd like to thank you. However, I want just to add that all references that are used in this book are linked in this link here that you can click into it. These include books of scholars such Al-Hawi, Al-Qanun, as well as two of my articles co-authored by my colleague, Dr. Ayman Al-Hindi. These articles have many other references that if you are interested, you can go and refer to them in more detail. Again, thank you, and I'm ready for any questions.
Jazakallah khair. That's Barakallah Feek. Jazakallah khair, Dr. Hossam. It's fantastic presentation. It's really very informative. I'm very pleased, actually, you touch on many aspects and the influence of these scholars on our modern practice as well. I mean, I know in his book Al-Zahrawi, you mentioned yourself Al-Tasrif liman ajiza an al-ta'lif. He probably maybe put over 10 chapters for obstetrics and woman cares, and he's been given lots of credit, as you mentioned, the forceps he made to restart the fetus, the mishdakh, and also, as you quite clearly said, the case report he mentioned on the ectopic pregnancy, which has been credited to him in few articles. Barakallah feek. I'm quite happy to take any, if there's any people would like to raise hand and put questions. If there's any questions, please feel free. Anyone? I know the presentation is really very informative, lots of information, and mashallah, you touched quite extensively about Al-Zahrawi and Ibn Sina, Al-Razi from his book Al-Hawi, and Ibn al-Baladi.
Can I go ahead with my question, comments?
Dr. Ayman.
Yeah, thank you. I also put my comment in the chat, but maybe
feel free, Akhito.
Yeah, thank you. Dr. Hossam, amazing, mashallah, as usual. Jazakallah khair. Sir, I can't turn my camera. I'm not properly dressed.
It's all right, Akhi, no problem. Dr. Ayman Hindi, take care.
Thank you. Yeah, this is Ayman Hindi from Chicago. I had really the privilege and the honor to work with Dr. Hossam for a while. And as he mentioned, we co-authored 2 articles together, and I'm hoping for more in the future, inshallah. Yeah, that's amazing. Thank you for doing that. I put a comment or a question in the chat. And of course, we discussed that, Dr. Hossam, as you know, many times. Why do you think that many of the modern books, the classic textbooks in OBGYN, of course, there's always the first couple of chapters. They talk about the history, whether it's gynae or OB, etc. And there is, I don't want to say deliberate, but there is a real kind of omission of the contribution of the Muslim or those, and many of those actually were not Muslims, of the scientists generally working during the Islamic Golden Age. Some of them were Christian or Jews, but those who worked in that era, 700 to 1400, they talk about Galen and the Greek contribution, and they somehow have a lapse of memory for 700 years, and then they talk about what happens in the Renaissance after 1500 and so on. I wonder if you want to maybe comment on that.
I mean, the comment is really, I don't know, we can call it bias or what. I mean, probably more bias than anything else. Fortunately, in the more recent history of time, some of them did start to correct this problem and start looking to these contributions and reporting on it. And as I said, some of these are reported in our publications, some references to that. For example, I can quote one of these authors, recent authors. I don't want to get these pictures here. Not pictures, I mean. In his article in 1973, there are 2 authors, Pink and Lewis. They say that attention is especially drawn to the gynecological and obstetrical instruments used by, quote unquote, the Arabian. He called it Arabian, no other than Muslims, whatever, Arabian doctors. It is shown that in this branch, at least, the Arabians were by no means wholly dependent upon the classical writers. They altered and improved out of recognition the ideas they received from these classical sources. He continues to say, the speculum, the forceps, the lever, and the crochet mark in a special way the original Arab genius. It is also shown that the Arabs had developed a clear practical idea of what is normal or what varieties of abnormality were to be met with, and by no means least of prognosis in obstetrics practice. So he specifically talked about the contribution of Arabs in a very positive way. He called them Arabs, as I said, not necessarily Muslims.
Right.
But that is an example of one of the more recent Western authors that have that kind of mention. But as you said, there are very few that have done that.
Can I add something, Dr. Hossam? I think that really will show our responsibilities. The people, the clinicians who are interested in the history of Islamic medicine, I think we need to work a bit harder to put all these contributions to document it, to probably maybe write about it. And I think I can tell the mood start changing over the last maybe 20, 30 years now in the West, because more and more articles being written from Western people and books as well, and giving the credit to the right people who discover this. I can see Professor Dr. Nasser Shaban, he put some questions. If you want to add or put the questions, or maybe raise your hand or you mute yourself. I mean, he's asking about who invented the ectopic pregnancy. Do you want to?
Yes, Assalamu alaikum, Dr. Hossam.
Wa alaikum salam.
Alaikum salam wa rahmatullahi wa barakatuh.
I was asking, I was following up on that part of abdominal pregnancy that Ibn Sina, if I'm not wrong, or is it Dr. Zahrawi? Who invented the abdominal pregnancy. But I think if we have any information, or I was asking if we have any information on who invented the ectopic pregnancy, because of it, the occurrences. I mean, we have more of ectopic pregnancies than abdominal pregnancy, and I'm sure even during those times of theirs, they had mortalities secondary to ectopic pregnancy. So do we have any history on that? That's what I was asking. Shukran.
I did not really come across the description of the more common ectopic pregnancy. Obviously, abdominal pregnancy is 1% of all ectopic pregnancies only. So it is very rare, like it is 1 in 10,000 of pregnancies, basically. But you are right. I don't remember at least mention reading of ectopic pregnancy that is the more common one, that is in the uterine tubes, fallopian tubes. Although that's as dangerous, because obviously it can cause maternal death as well. But apparently that was not recognized as such at the time. At least I did not find any evidence of it.
Jazakallah khair. Any more questions? Anybody would like to quick contribution or
I just want
comment?
to comment that, as I said, this is our duty now, as you said, to dig into these historical things and try to collect this information and try to publish it. And that's what we have been, quote unquote, trying to do with these two articles that we publish at this time, one about obstetrics and one in gynecology. And I understand that we meaning that in the United States here, we have in Chicago, the Institute of Islamic Medicine, the Nagamia Institute of Islamic Medicine, had the project of editing a book about contribution of different of Muslim scholars to different disciplines of medicine.
I think the first volume is coming in few months' time, inshallah, after he passed away last year.
Right. The first part of it, I don't think it will include all the stuff, just some of the items, some of the branches. So anyway, it has, I think 2 or 3 parts will be, and hopefully, as you said, it will be published in the first part will be published sometime next year.
Inshallah. Dr. Lillian Prince, you want to join and put a question, please?
Yes, thank you so much. You can hear me, right?
Yeah.
Okay, thank you. I'm not a doctor yet, but with Dr. Al-Handy's help, I will eventually become doctor. I'm one of the members of Dr. Al-Handy's lab at the University of Chicago, and I study uterine fibroids in women of African descent. So my question specifically, but first let me thank you for this wonderful information. So fascinating to learn. So I'm looking forward to learning even more. And reading the works that you mentioned will be forthcoming. But my question is, I know, Dr. Fadel, you mentioned that Dr. Ibn Sina used, I think it was Dr. Ibn Sina that used herbs. And I ask about herbs for the use of uterine fibroids because during my research, I saw 2 articles, one from researchers in Ghana and another from researchers in Nigeria that used herbs, and basically they sewed them into the vagina for the treatment of uterine fibroids. So I was wondering, in your research, did you Do you know, or did he indicate what specific herbs those were, and were they successful in the treatment of uterine fibroids?
Thank you for the question, but I mean, the herbs are mentioned in the book. And the book is, as I said, its name is Al-Hawi fi Tab, or the continents, and it is available in my reference list here. But I did not go, frankly, in details about the different kinds of herbs. These are probably beyond my ability to understand all the herbs and the horticulture, or whatever you call it. The science of these herbs is too much for me. So I would leave it to some other researchers that are familiar with the different kinds of species of herbs. Because there's a lot of these herbs mentioned by name. But as I said, I did not pick any particular one that I investigated or decided to study to see if really it worked or not.
Okay, just to add a quick point, Professor Hossam, Al-Zahrawi himself, when you mentioned his book Al-Tasrif Liman Ajiza An Al-Ta'lif, he described all the surgical subspecialties in over probably maybe 85 chapters. Right. This all in the last volume of his book. The book has got 30 volumes. So all these surgical specialties, all on the last volume. And the remaining 29, he talked quite a lot, over probably 20 volumes on the drugs. They call it al-adwiya al-murakkaba or al-adwiya al-mufrada, meaning the simple drugs as well as the complicated one, when he add different drugs, and he made his own drugs, as well as he used the herbs. Obviously, for himself as a surgeon, he need something, probably maybe cream, ointment, antiseptics, as well as probably maybe to help sedation for the patient when he does the surgery. I think you are right. We need to probably maybe dig a little bit deep on the pharmaceutical discoveries and what they use, and the different materials they used for each condition.
Yeah, that's very true.
Thank you. Thank you.
Any more? Any other questions? Okay, I think we can probably maybe come to conclusion. Jazakallah khair, Dr. Hossam. Inshallah, we'll make this session available online, and we'll probably maybe. I think we've got another question, isn't it, Sandrine? I'm sorry. Okay, we'll take this question, please. I can see the hands being. Is that mistake? Okay, fine.
No, there's a question there. It's by Ali Habib. It's by Dr. Hussein Ali Habib, about the midwife errors, and then also about the fate of the women. It's at the very bottom of the chat.
Okay.
Mm-hmm.
I'm sorry, what's the question?
What was the fate of the woman who failed the garlic test?
Oh, the fate? No, I mean, she was just told.
They offered any abdominal delivery equivalent to the cesarean section? I think it's just probably maybe asking what would they been doing if normal delivery wasn't really performed. So in some difficult delivery, if the physician, this scholar, cannot really make a normal delivery, did they use a cesarean section?
No, oh, no. The early Muslim scholars did not resort to cesarean section, to my knowledge, early on, but later on they did. In the 15th century or 16th century, there was definitely evidence of using cesarean section. Like even in some of the illustrations by some, not I forgot, Al-Biruni. I think there are some illustrations of deliveries by cesarean section. So it was practice. However, there's no really text that I did find about it, but it was used, and there is illustrations to show it has been used. Particularly for, I don't want to say that, like for example, what I forgot now, I'm sorry, one of the known emperors, whatever, Rostam, his name, I believe, supposedly was delivered by that kind of method, abdominal delivery. In the, at least the Persian culture or Persian myth.
I mean, you mentioned the Turkish surgeon, very famous. I mean, Sharafuddin Sabunji Oglo. He wrote a big book, and this is again on the 1500s. They probably maybe expanded on what previous surgeons like Al-Zahrawi did. I think we all agree we need more research, more detailed books on articles, inshallah, into this topic. Jazakallah khair, Professor Hossam. It was great to have you here this evening, and it's probably maybe morning time in the States. Inshallah, we'll carry on this series for the FIMA History of Islamic Medicine, and we'll meet again. Please keep an eye on the next session. Jazakallah khair. Thanks very much.
Thank you very much. Thank you. Assalamu alaikum.
Assalamu alaikum.